So welcome to this regular Wednesday Biomechanics Q&A with myself, Rachel France, Biomechanics coach, lover of all things biomechanics, movement, exercise, human body related. So hello there over on, hi Niall, Mags, great to have you along again. Leanne, how you doing? So we've got the guys checking in over on Instagram. This week, we've got two fantastic questions yet again. So thank you, Magda and Amber, I believe it was. And I've had a couple of people actually, based on the conversations we had last Wednesday about scoliosis. So while I've got some very specific questions come in, I'm going to try to, as each week, I've got to try and be generic, and so I can often get very specific questions coming in, but I have to generalize to be able to recognize the audience that may be watching this. So whether you're watching this live right now or whether you're watching this as a recording, I try to, within a very short space of time, of course, answer the questions that come in, at least in a way that helps the person who's asked the question to maybe do some more research, or maybe it gives you insight and they get their answers. But I think what can help us, you, me, collectively, us as an industry, that's the movement world and the therapy world, is when we have conversations around certain topics like scoliosis, when we're working with an individual who may come along with scoliosis. How do I help that individual? What does that mean? The big so what question. So what I'm going to do is, as usual, offer everybody who's watching this live to ask a question. If you do ask it when it's been recorded, I should get tagged. They're on each of my platforms, but do feel free to ask as we go. Hi Reshma over on Facebook, great to have you along. So I will be flitting between, I'm generally looking at the Zoom guys because I can see you guys. Instagram, great to have you guys in. Feel free to ask questions as we go. I'll sort of relate to you the two questions, the two topics that I'm going to discuss today. We'll do them one at a time. We're going to go for about 45 minutes or so, and you can ask questions as we go. I will come in if you're patient, and I will come in. Hi there, Fiona. And I will endeavour to guide and point you in the right direction if I can't answer. So Reshma's come over onto Zoom. How you doing there, Reshma? I can see your face. How you doing? Welcome in. So the first question around scoliosis, I found this one a really interesting one. And actually what I like to share with you is the little knowledge that I have, and then what I would do if I was approached by a client who wanted to work with me, who has scoliosis, which kind of ties into these questions. So I'm going to assume that the people who ask these questions are fitness professionals who have scoliosis. So I'm also going to assume that you probably know quite a bit about scoliosis, probably more than I do, but we'll look at your questions and try and understand how we might be able to help clients who come to us who have scoliosis. So the first question is scoliosis. How can we train with scoliosis? So this is coming from an individual who has scoliosis. Or how could we train our clients who come with scoliosis? She says, if convex right thoracic and convex left lumbar, I'm going to talk about this in a moment, which is basically the direction of the curve. What would be recommended in terms of testing and exercising? Would it be stretch the concave and strengthen the convex? So really interesting way of thinking about it, and might sound logical, but I'm going to go into that in a little bit more detail in a moment. The third part of the question around scoliosis is, are strength and conditioning workouts safe for adults with scoliosis? As an addition to Pilates, for example, is the way the question was posed. So I have taught learners, practitioners with scoliosis. I haven't worked with a client with scoliosis. However, my best friend has had scoliosis and now has 3 metal rods in her back. And my relationship with her was originally as her carer. So I do have experience of the different types of scoliosis, which is what I'd like to talk about today. So scoliosis, in simple terms, is a lateral curvature of the spine. Scoliosis generally is thought of as a structural deformity, but I'm going to go into some definitions. So when you start to research causes of or types of scoliosis, which I'll go into, like any skeletal presentation, the difference in our bones can be in all sorts of ways. So we accept that we have different length femurs. So my femur might be different to John's femur length, and that's going to affect the way we squat or move. And then you have a series of joints, coming back to the original question about scoliosis. This huge kind of wondrous architecture of spine with all these multiple joint connections, the facet joints, the vertebrae, etc. I kind of wonder sometimes why we're so surprised when some people look different to other people. I think if we keep an open mind that scoliosis doesn't mean you're not normal, that scoliosis for an individual who has it is normal. I think where we're looking at is comparisons of different clients we usually work with, and then if we come across somebody with scoliosis. To be diagnosed with scoliosis, the clinicians, and it needs to be diagnosed by a clinician, by the way, using what's known as Cobb's angle or a Cobb angle, where they measure the degree of curvature. And anything over 10 degrees, if you go and do some research, so there's a little bit of homework for you now, is go and have a little research of Cobb's angle. Anything more than 10 degrees would be defined as a diagnosis for being called what we classify as scoliosis. More commonly seen in sort of puberty and young ages, and very often sort of by the age of around 10 years, it would be recognised if somebody has what would be diagnosed more than 10 degrees in the Cobb scale as diagnosis. And you can see that in several ways. Obviously, if there is a curve, if there's any asymmetry, and of course, if they are in any way symptomatic. But before we go any further, I just want to explore with you the different types of scoliosis. So there are different ways of classifying why somebody has scoliosis. So you can have the most common form, which is idiopathic. Now, idiopathic scoliosis is that there's no known reason why. So maybe that's just the way you're designed, or there's no single definitive reason why. The most common, and I would imagine that the lady who asked the original question, because she didn't give me any more information, is probably an idiopathic scoliotic case study. Because the other two classifications are congenital, which is a birth defect. So when the fetus is forming, something has malformed or gone wrong within that sort of growth period. So when they're born, the bones are different in their formation. And I think it is something like 1 in 10,000 babies are classified as congenital scoliotic or as a birth defect. And then you've got the neuromuscular conditions. So my friend has cerebral palsy, and she was starved of oxygen during birth, which caused brain damage. And so along with that neurological condition, because of the way the brain messaging works through to the muscles, as she was growing as a youngster, she had weaknesses that meant she was gradually starting to fall to one side. She was in a wheelchair, couldn't walk, couldn't take her own weight. So because of the cerebral palsy, she got scoliosis. Now the scoliosis that she experienced was quite severe, which is why she quite quickly, before her 18th birthday, I believe, had 3 metal rods put into her back because they felt that if they left her, she would have effectively suffocated herself by squashing her organs or lungs. So those are kind of more extreme ends. Now, I'm going to assume the people who've asked the questions are not neuromuscular, could be congenital, but probably more towards the idiopathic, which is simply where there's no known reason, that's just your design. So in terms of scoliosis, we can have different directions, different degrees, and this may indicate how much we feel or how much it disrupts our movement pattern based on what most people have within their spine structure and the way they move in terms of a comparison. So that makes sense. So idiopathic, the most common, usually diagnosed relatively early on within sort of puberty as they're developing. No single known cause, just their design. Then you've got your neuromuscular disorders, cerebral palsy, or neuromuscular conditions. I think another one example was muscular dystrophy. And you can imagine how the effects of muscular disorders or neuromuscular disorders, they're going to affect how well we support the body. So it just makes sense that that is going to affect the way we form as the bones are soft and as we're starting to develop. So neuromuscular and congenital, which is where it's a birth defect. So I'm just going to push those aside for the moment. I have to make the assumption because the question was a generic one. So I'm going to imagine there's no other conditions going along with it so that we can explore different language and definitions. And then obviously the training program, which is what the original question was about. Now, there are different names for the different directions of curve as well. So I learned this from them asking the question last week. I didn't know this before. So if the scoliosis means that the curve is going to the right, so if it's going that way, it would be classified as dextroscoliosis. So that's a leftward shift, not a left bend, sorry, a right shift, not a right bend. So if you're bending, upper body is bending to the left and the scoliosis is shifting to the right, that would be classed as dextroscoliosis. If it's going the other way, it's called levoscoliosis. So that was new to me. I'd never heard those terminologies. Does it change what we do? Not necessarily. It would depend on if that affects different organs on the inside. So these are the sort of things we want to be mindful of. So symptoms of individuals with scoliosis may be none whatsoever. If there's no symptoms, in my head, the logic would be kind of carry on as normal, but maybe alter expectation. And an example would be if you are doing spine mobility tests like lateral flexion or sagittal plane flexion or extension or rotation, I would alter my level of expectation on somebody who's diagnosed with scoliosis. You would have to, because the motion between those joints would have been altered due to the concavity or convex nature of the way the spine is presenting. So if I was doing a spine rotation test one way and the other, on a client with a level, if you like, spine, I would want to see around 45 degrees in either direction through the thoracic spine. On an individual with scoliosis, I would simply take a benchmark of day one, and if I felt or they wanted more movement, then I would just measure after that the same test. I'd reproduce it to see if we achieve different ranges. Does that make sense? So every test we do on any human with or without scoliosis is a benchmark. If somebody has a skeletal difference, they have scoliosis, then we need to alter our expectation. It doesn't mean we cannot improve their spine mobility. It alters our level of expectations. That's the key factor I want to put into this. And I think it was Magda who asked this question. So for Magda, she's asking about specifics of testing and exercising. So I would test you exactly the same. I would have you seated in a chair to remove any movement of the pelvis. I would want to see what your spine looks like in flexion, extension, lateral flexion, and then of course rotation. I would film and photograph with your permission, and I would take that first session as a benchmark. I'd write down my scores, my measurements, or my analysis of that. I'd ask you how you feel in each position. And then what we do is we work together to understand what we're trying to achieve, whether we feel it's realistic. And then I would monitor you each week or session, do the tests again, and see if we get improvement. I'd also want to work with a client on their own expectation. And it might be that I would be encouraging them towards more expectation if they think, that's it, if I've got scoliosis, I can't do rotation, for example. I might say, well, actually, you might be able to, shall we try? Or there may be clients who think they can do more than might be possible due to their skeletal presentation. So it's very much a case by case, as I'm sure you will recognise from all of these biomechanics Q&As, is I always have to kind of say, it's going to be always a very much a one-to-one situation. So I try and give examples of different client types, maybe different ways that they present in their scoliosis. So they could have purely thoracic scoliosis. They could have thoracics going one way, the lumbars going the other way. And in the research that I did, actually somebody who has both thoracic and lumbar scoliosis, it usually is less visible. They kind of balance each other out. Whereas if somebody purely has a levo scoliosis, is it to the left when they shift to the left? Levo scoliosis, they would look more asymmetrical because it hasn't balanced out with an opposition curve lower down. Does that make sense? So actually two curves could be better than one in terms of looking at symmetry and the way we train a client who has scoliosis. So understanding x-rays or diagnostics and measurements from the clinicians is kind of important in one respect to understand where the scoliosis is occurring, which could change our expectation. But ultimately, one thing to keep in mind is there could be an appearance of scoliosis due to a functional issue. So we have in the past talked about a leg length discrepancy caused by dysfunction at the hips. And so if that happens, what could happen there is we could be standing with dysfunction with a hinge, so a muscular dysfunction, which is just from driving, from carrying a bag on one side, from playing an asymmetrical sport that creates a functional scoliosis. So the previous conditions I've talked about are more structural or medical conditions, but then it's keeping an open mind to a functional scoliosis. So we as movement practitioners, unless we're qualified to do so, should not diagnose structural or functional scoliosis. As a biomechanics coach, what I would do with every client after a full case history is observe the spine in just a neutral position, go through the testing, and if there's anything in there, I might further question, and they may share that they have structural scoliosis or maybe not, but I do see a scoliosis. So I'm just going to keep an eye on that. I wouldn't say to them, I think you've got scoliosis, but I think you understand where I'm coming from with that one. They can have an appearance, so anybody with scoliosis, structural or otherwise, can have an appearance of an asymmetrical bulge at the back. And that can be how the soft tissues can adapt. And it might be where they feel discomfort, it may not. Because if the structural systems are off-center, this can cause the muscles to hypertrophy or atrophy in different ways as well. So you can get these adaptations and differences through the soft tissues. Certainly their attachment sites can be different lengths or their origin to insertion could change depending on where the curvatures are. And it's just being mindful of that. Now, a third consideration is structural scoliosis with a functional scoliosis on top. So that's kind of where I want to talk about Magda's example, where we might have a client come to us and say, I have structural scoliosis, so I'm not going to be able to do certain things, or it's this amount. What I wonder, and again, this is from a non-clinician, my background isn't in clinical practice, I do work very closely with clinicians, but if the body is in a structural deformity curving to one side, in my head, logically, gravity would surely add a potential extra amount, or it could, of functional asymmetry on top of that. So can we straighten structural scoliosis? No. If somebody is born with bones that are formed into a curve laterally, or a scoliotic curve more than 10 degrees, you can't change that. Could some of the curve that they present with be additional to what is structural? Yes, I do believe that is possible. If it's possible in somebody with a straight spine, why would it not be possible to somebody who's already got scoliosis? So what? So what does all this mean in terms of exercise prescription, which is really where the original question came from, but I just needed to kind of set that all up prior to answering the question. Now, you can do a lot of research into scoliosis, a huge amount of information out there. Please always check your source. Make sure it's a valid, a good source, rather than Barry down the gym who's got it and he's done this and that's what happened. Good old Barry, whoever it is. Great options are things like swimming, walking, short distance running, where you've got that symmetrical, the water's great, there's no gravity, and you can move the whole body in the water, using the water as resistance. That would be one option. Walking or running shorter distances, and again, this is going to depend on the individual. So I don't want to patronise anybody by any means and say that somebody with scoliosis can't go hiking or run a marathon. I don't want to say that, but sort of lower distances for the lower repetition might be advisable to somebody who is scoliotic and symptomatic. So I think the symptoms play a big part in here. If you're not symptomatic, fill your boots, go for a hike, get moving. At least right now, that's about all we can do. I think things where we need to consider are things like, in youngsters in particular, I know that there's some of you in here with youngsters who have scoliosis, considering collision sport and asymmetrical sport. So somebody with structural diagnosed scoliosis, considering an impact sport like rugby or martial arts, and also sports that are very asymmetrical like tennis or any kind of racket sport. Not saying don't, but again, case by case, we would want to understand symptoms versus risk, which is ultimately what we're discussing here. Also looking at individuals considering exercises like heavy weightlifting, weightlifting at speed like the Olympic lifts, things like horse riding, which is very much a triplanar motion through the spine with the hips relatively fixed, where you've got that frontal plane, sagittal plane, frontal transverse plane motion through the spine, could for somebody with scoliosis start to increase symptoms. So it's not saying if you've got scoliosis you can't ride a horse. It's saying it may be one that you consider whether how badly do you want to do it? What's the risk? Can you achieve a successful horse riding lesson, session, or ride without pain? And kind of understanding for the individual how important it is and what we can do to help if that's something they want to do, and versus the risk that it might bring in. So just to make sure I come to the original question, asking about specific questions for somebody with sort of convex right thoracic, convex lumbar, convex to the right on the, and I don't know which way that means. Convex I know is going in, convex right thoracic spine. So I'm imagining what she means is convex that way and convex left. I may be completely wrong here, maybe the other way around, but let's imagine it's this S shape she's describing. She's asking, would you stretch the concave and strengthen the convex? Convex is the longer side. From my research of reading, and I haven't trained somebody with this type of scoliosis in a gym in the exercise world, a lot of the recommendations are to use symmetrical stretches like a child's pose, so that when you're in that straight position, you're going to feel stretched on one side and not so much on the other side. So symmetrical stretching. Also exercises like rowing, so a symmetrical movement to strengthen the back musculature. This is all going to be case by case. This is all going to be in a setting where you would see how you feel. Planks recommended, or static core training. You could do that supine, kind of dead bug type of stuff to strengthen the muscles around the spine. Could you do what this lady has suggested and stretch the side that is closed off and then strengthen the opposite side? I think we need to be careful about the volume of stretch and strength opposition work, asymmetry work that we do on the spine. Could that have a detrimental effect? So what would the dosage be? What are we trying to achieve by doing that? Are there safer ways of training with scoliosis? So this isn't going to be, as you'll recognise, Magda, a direct answer to your condition, because I would need to understand much more. What you've suggested kind of has a logic to it, but be careful in application, because if you only ever stretch and strengthen, then one side never has strength in there, and we shouldn't underestimate the value of strengthening the whole body, even with a presentation like scoliosis. So I'm going to just pause for a moment because it may be that has brought up additional questions. So Zoom guys, feel free to ask questions. Kath, yes, I'm going to be recording it. Hi there, Helen. Nice to have you in. So the idea being, I don't have all the answers. I'm just expressing from my experience of working with, which is very limited, as you can hear, or experiencing training somebody and using sort of a logic of what I understand about the human anatomy, the bones, the muscles, the nerves, how they work together, and then the differences. So I encourage you, Magda, I'm sure you've done loads of research on scoliosis. If you have a condition, you generally do. And so I'm happy to talk to you again afterwards. I'm sure you could teach me a few things. But the research I've done, and then the little I know about scoliosis, what I wanted to share is how I would respond. So I hope that helps. Anybody got any questions or any feedback on that? Just come and check in over on Instagram. How you doing, guys? Just check if there's any questions in there. Hi there, guys. Don't think there's any actual questions come in, just loitering in the background over there. Facebook, we've got Kath and Helen, so we've got some amazing instructors out there. Hi! We've got Bev, Amber, I'm coming to your question in just a moment. Lyle, amazing. Amanda, welcome. Amazing. So we've got a whole bunch of fit pros in here, so let me reach out just for, let's have 5 minutes. Has anybody out there worked with clients, or do you have scoliosis? Based on everything we've talked about up to now, how would you train somebody with scoliosis, or what would you want to impart here to the groups about working with somebody with scoliosis? Just going to come over, there's a comment coming through on Facebook. So Roz, learning a lot, really interesting topic that I've not done. Yes, same here, Roz. Very limited for me as well. But what I like to try and do is, when I do get asked a question, rather than saying, I've got no experience, don't ask me, I think, right, this is an opportunity for CPD, I'm going to do a bit of research. Coincidentally, my best friend had the neurological scoliosis based on the fact she had cerebral palsy. So having 3 metal rods in her back, and she still actually, with those rods, is very laterally flexed. So even though she had the rods put in, I think it was just before her 18th birthday, she'd already kind of formed, she's Her head goes to the right, so she is a levoscoliosis formation, single direction. She is now more so symptomatic than she has been before, and she's nearly my age. So sort of late, in fact she was 50 last year. So, and she's confined to a wheelchair anyway. So she isn't the type of client that we're really probably going to come across who would come to us for exercise. However, I did train her, I did massage her feet, and her primary choice of exercise was swimming. So just let my mascot in. Come on then, if you're coming in. So even with cerebral palsy, she would go into the swimming pool, and she liked the feeling of the opening of that side of her spine. She had success with bowing therapy, whereby, again, that's sort of a bit of a hands-on, which would help to open up and allow her to feel deeper breath. But she also had these metal rods in, so there was a lot more complications for her. So, Bev, lastly, I have a wonderful teacher who has S-curve. She runs a course that hoping to get on when lockdown ends. Yeah, so I think if you have scoliosis, you have clients or family members with scoliosis, who says hello, Broxy, it's probably worth following Bev's advice and looking for training in that field. Or if you're thinking, I fancy doing a CPD, what can I do? Even understanding something like scoliosis can help us appreciate skeletal abnormalities or deformities. I'm cautious of using that language. Differences is probably the best way to describe it. And we actually have more than you would imagine, because there's so much soft tissue over the top, we often can't see how different we are on the inside. And yet when you train 100 clients, you start to appreciate, actually, we're all quite different on the inside. There may be, I think it's, the research I did looked at, this was an interesting statistic I came over as well, bear with me, which is a recent study, and I've got to find out where it was, shows that 60% of older adults have degenerative scoliosis. Do you remember I talked about that functional scoliosis may be caused by functional leg length discrepancy, pelvic dysfunction, QL tension more on one side, and then over time, degeneration on one side, and we hear about herniations at the extreme end where the discs kind of push through on one side. All of this would make it logical that in older age, there's more of a chance of us presenting with degenerative lateral kind of curves in the spine. That would kind of make sense to me. That wasn't surprising. Idiopathic scoliosis, 30% of adolescent scoliosis is that idiopathic. And so they're suggesting there may be a link genetically. I found that surprising. However, then I challenged my own thinking, because my bones will form in a familial fashion to my grandparents, my parents, and so on. So my family, I believe, has a genetic sort of disposition to a femoral anteversion, where the femur head is rotated more one way beyond the kind of norms. So sometimes I catch myself being surprised, and then I challenge that and I think, well, why am I so surprised? The body is a wonderful piece of architecture, and we all look completely different to each other. You know, we might say, well, everyone has 2 arms, 2 legs. No, we don't. Some are born without legs, you know, so to appreciate how different we are on the outside with skin colour, tone, muscle size, femur lengths, arm lengths, joint design. It's the same on the inside. So we maybe shouldn't be surprised when people come along and we hear these kind of statistics. And this is what I kind of love when we talk about the body, biomechanics, human movement, is the wondrous nature of it. And when we go through our level 2, level 3, and everything's it goes from here to here and it does this. And then you go level 3 and you train a few clients, and some do this and some do this, and some you know, and you start to appreciate actually we're all quite different. So the case by case idea becomes more and more profound. I know I'm speaking to those who recognise that. So let's just have a quick check. You welcome, Mags. Yeah, no problem. Let me know if there's any more questions. Just quick check in over Facebook. Right, okay. So question 2 is from my friend Amber. And she asked, what do you recommend for the position, great question by the way, I've got to say, of the shoulder blades in strength exercises? Many of us are taught to squeeze your shoulder blades together when performing certain exercises like rows and deadlifts. So that's the original question. She added into that, the more I'm learning about healthy shoulders, the more I'm understanding the scapulars need to move freely, not be locked in place to avoid injuries. Are the teaching cues outdated? Is it more beneficial to let the shoulder drop towards the floor before performing an exercise like a single row? Great question. I love these kind of questions. And I've kind of alluded to some of the answers in some of the previous 30 minutes conversation. So if you have just dropped in, you can watch this back. I will upload it over on YouTube. If you haven't found the Biomechanics Education YouTube channel, if you go over and subscribe and scroll through, there is a whole year's worth. How long we've been locked in? Is it a year? Feels like a year. It's almost a year. There's a whole lockdown series of these Biomechanics Q&As. So you can go back, and if you're really, really bored, you can listen to me talking about all this stuff. So you can go and watch all the back catalogue. It's all there. Every lockdown we're doing these for free. So do I recommend squeezing the shoulder blades back for shoulder health, which is, I think, where Amber is coming from. Okay. So this is again where we go from basic training to then real world training. I think if we understand the way the shoulder works and functions, that's the key component that's going to help us understand how to train the shoulder. So kind of both are right, Amber. I'm glad you've challenged it though, and I want to encourage you to continue to do that. But let's just have a quick look at shoulder design. Now, I've just literally, again, if you go to the biomechanics.com website, click on blogs, I've just done a whole series. I've not finished them yet. I've done pelvis, spine, shoulders. I'm just starting to launch knees, and then feet will be next. The 2 shoulder blogs talk about the shoulder bones and then the shoulder muscles. So I'm going to give you a snippet. But if you want to go and look at that in more detail, go and check it out on the biomechanics.com website. Blogs, shoulders. When you consider the design of the shoulder, the muscles are actually really, really important in a joint like the shoulder. Now, we classify it as a ball and socket. But if you compare the ball and socket of the hip, where the ball literally sits inside the socket, so our body weight is over the top, it's our propulsion point, if you like, in the middle of the body. When you look at the ball and socket of the shoulder, there's not really a socket if you compare it to what we've got at the hip. So your humeral head, obviously there is a ball there, but when you look at the glenoid fossa or the glenoid cavity, the shoulder doesn't, the ball of the head doesn't really sit inside a bony encasing in the same way. Then the way that the shoulder joint or the bones of the shoulder meet, so you've got your clavicle, your acromion, your scapula, and your humerus. So the humerus attaches to the body through soft tissue. So this is what we're going to talk about more in a moment. Then you've got your AC joint, which is where the acromion and the clavicle, hence AC, meet. So as you can see, that's a very kind of tiny attachment. In fact, if you take your finger, slide it over the head of the humerus, you'll feel a kind of a groove in there. If you come back off that, you can kind of locate your AC joint. Yeah, it's actually, again, quite a small bony connection. Then we look at where the clavicle meets the sternum. Again, a very meager connection point. So if you place your palm on the opposite clavicle, lift your shoulder up and down, and you'll feel it should hopefully move around. It almost floats around, doesn't it? Kind of like really, it's got a lot of movement in there, or hopefully it's got quite a bit of movement. And then you've got where the scapula sits onto the ribs. So the actual bony connections are quite tenuous. And that is to allow the shoulder lots of movements, which is great. But it's also a problem, because if the shoulder musculature isn't fully functioning, if the joint strength ratios are off, if the nerves are tight, that can actually mean that those gross movements become slightly contraindicated or problematic. So we want the scapula to move nicely around the ribs, around the upper body, to allow us to press, to push, to pull, to extend, you know, to help, because the scapula will dictate how much your thoracic spine moves. If the scapula is stuck forwards, because your protractors are stuck in this position because you sit at a desk all day. In fact, everybody watching, do this, do this. Pull your shoulders forwards, do that. Let's pretend and exaggerate overactive protractors in the shoulder. So do that, go in this position. Yeah. So our pec minors are tight, in spasm, whatever you want to call. So keep this position and then put your hands over your head. If you can get them there, it's going to feel uncomfortable and clunky, because the head of the humerus is in the wrong position to pass by that bursa. This is where we can get impingement issues, and it can be a problem. Go back into this position again, and with your shoulders sat forwards, extend your thoracic spine. You can't extend your thoracic spine without the shoulder blades coming back. Can you feel that? If your shoulder blades are forwards, they will limit the movement in your thoracic spine. So there's this whole integrated system that can impact on the way the shoulders move, how much they contribute. Now, in my experience, Amber, not always, but in my experience, often the shoulder joint is doing too much movement, because most people have a very stiff thoracic spine, because quite a lot of people have desk life. Desk life where, yeah, sitting at the desk, getting the fingers all onto the keyboard. So not always, but it's a common issue that we see. I think we can all recognise that. So I just want to set that tone first of all. Then when we look at the muscles and the way they interact across the shoulder, and again, the blog that I've just launched is over on the website, goes through all the muscles and all their jobs and their roles. They all have different parts to play in internal, external rotation. So your subscapularis, your infraspinatus should oppose each other antagonistically in medial and lateral rotation, or internal, external rotation. They should work together in adduction. So if your arm is out here, then they will work synergistically. How cool is that? They're antagonists and they work together. Amazing. But actually, the ratio of strength between internal and external rotation needs to be, it's around about the 60-40 mark. If you have a strength ratio that isn't quite right, that can throw off what the whole shoulder structure is doing. Because other muscles will have to take over, they'll have to help out where the muscles are not doing what they should. So what I'm setting up, Amber, first of all, is when we think about strengthening the upper body and moving the arms around, number one, we should be preparing the shoulder joint first. Making sure that the spine moves really well, making sure that the small isolated actions of the shoulder are possible. Can they do this? Can they do this? Can they do this? This? And how do those Comparisons, how do those strength comparisons relate? You can go and do some research on strength ratios before we consider the gross movements. Now, coming back to the original question about scapular motion, if any of that structure is weak, and then you put a heavy weight in your hands and try and lift it off the floor, what's going to happen at the shoulder? There's going to be a lack of stability and control. Now, why would we want to do a deadlift? Is that to train the shoulders, or is it to train the hips? What are the prime movers in that, and what are the roles of each action and movement? So we need to explore all of that as well. So if we were to take the deadlift is a strength move for the hip extensors, and to be able to work the hip extensors, I need my shoulders to allow me to pull a weight away from the floor. Now I could do that with the shoulder blades either retracted or protracted, or I could add in, from protraction, I could add in a retraction roll at the top. And actually, technically, there's an argument for all of those. So it depends on what you're trying to achieve. Now, most people, and this is probably where I think the way we're trained comes from in terms of the original question, most people have this problem. It's a rarity that we see somebody with this problem. Yeah, unless they're really proud of their genetic makeup in their upper body presentation. I don't have that problem. Anyway, most people have this as the problem. So we talk about, when we're doing a strength move that involves the scapula, we talk about pulling them backwards, and that will contribute to, hopefully, the positioning of the body and posture. So when we're taught at level 2 and level 3 about strength moves, rows and deadlifts, everything is about having the body in neutral, midpoint, good posture. We could argue all of that and say, what is good posture, what is bad posture? That was a whole other Q&A. I think I did it about 3 or 4 weeks ago. So if you want to go and have a look at that one, where we talk about bad and good posture, what are they, what does it mean? So go and have a read of those later on. But just to come back to that point, if you look at a client, I generally look at the way they move. I will assess them as a biomechanics coach. I'm going to assess their shoulder anyway. I'll assess the subscapularis. I'll just assess their infraspinatus, the upper traps, the median nerve, the pec minor, and I would evaluate how well each of those muscles contribute to shoulder function. I take that assessment and then I prescribe I move freely exercises, which are muscle energy techniques, antagonist strength training to use that law of reciprocal inhibition to improve the position, the movement and the function of that whole shoulder, to create a healthy shoulder joint first. Part of that might be, I'm not going to say to a client whilst I'm helping their shoulder function improve, no deadlifts, you can't deadlift. So I might, for a client who needs, let's say they do sit at a desk like this, and I want to work the antagonists to the pec minors to improve their scapular retraction. So I might say to them, when you do your deadlift, I want you to start with your shoulders forwards, pull them back, and then stand up, and then come down, and then lower the shoulders. So they're getting scapular retraction and then hip extension. So they're getting that combination of things. So I think, coming back to the original question, I think both are right. I think you're right to challenge this, Amber, in terms of your shoulders shouldn't just stay locked. No, they shouldn't. They should move around in natural movement. In terms of a deadlift or a row, it depends on why you're doing that movement and the healthy biomechanics of your client's shoulder. So to be able to answer the question, I might do both. It would depend on the client, the goal, and the biomechanical assessment that I would do on their shoulder. How well do the retractors function in comparison to the protractors? Can you test that? Can you design a program that improves that strength ratio. So scapular retraction is actually a strength move I will layer in right early on, and it might be that I would get them to do scapular retraction rows first. That might be reps, sets for a few days, or it may be in the same session. And then if they're able to do that with a decent weight and they feel good, I might then add retraction row. And then eventually, when I'm generally working shoulder extension, I just get them to row. So it may be that I use both or all of those to almost periodize their shoulder biomechanics program to improve the whole function of the shoulder. So in some respects, both are right, but I think what you're challenging is that you should just have the shoulder blades back and together all the time. I agree with you, probably not. But what does it mean to the individual in front of me when they want to improve their shoulder function based on the movements we're doing, deadlifts and rows? What am I trying to achieve there? Do I want thick rhomboids and back muscles? If I do, don't forget to look at the front, because the muscles at the front of the body can inhibit the growth of the muscles at the back. So if it's aesthetics, this is still important. And so understanding agonist-antagonist relationships in terms of basic function, and then also exercise prescription on an individual basis. So I'm hoping, Amber, does that help with your question? If you've got any more questions based on that, we've still got sort of 5 minutes or so if you want to post any more questions. Bev says, use the force sign and some of the biomechanics releases 4 by 20% for the pecs too. Yeah, definitely. Is there a latissimus dorsi one? Well, I'm going to pass this back to you, Bev. What do the lats do? Helen. Yes.
Okay, adduction.
Adduction, shoulder adduction?
Yeah, I believe so.
Anything else?
Internal rotation?
Internal medial rotation. So
right.
Do you know how to apply 20% effort on a static contraction on adduction or internal rotation? Yeah. So if you're wanting to, you're very welcome, Amber. So in response to Bev's point, if you want to apply an exercise to a muscle, look at its function, look at its action, and then load it in that direction. It's the same with the muscle energy techniques. You can make all your own up now. You can make your whole IME Freely class up. In a group class, so good question. Reshma's just asked in here a little while back. In a group class, goes back to the scoliosis question. If someone says, I have mild scoliosis, what should be my reaction? No, I'm joking. If somebody says they have mild scoliosis, I would want to understand, have you been diagnosed? Are you symptomatic? Do you think it's going to be a problem? Most people who have mild or extreme scoliosis, they usually know a bit about it. So I want to know why they're telling me, and if they're symptomatic is number one, primarily. And in a group setting, even in a group class, I would want to have done a consultation on all the individuals coming on to group classes to understand if I need to alter, adapt, or be aware of anything, which I'm sure you do that, Reshma. Does that pose any more questions for you? I'm just having a quick look over, see if there's any questions on Instagram. Hi, Instagram. I'll try not to be gormy as I come down and look at the script. You know when you're kind of looking at the script, you get that gormy looking face. We've got a few over on Instagram as well. Okay, you're very welcome, Amber. Okay, so I think that is, I think that's everything. Based on the 2 questions, you're very welcome, Bev. Scoliosis, how do we train a client with that? If you've just joined in, I know people are dropping in and out over on Instagram, then you can watch this back, and we talked about half an hour about scoliosis, what it is, what it means, how it's measured, different types of scoliosis, how we might train a client with scoliosis. But I would always want to have the diagnosis or the medical report where possible so that I can act on that. You're welcome, Kat. See you soon. And then we talked about shoulder strength training, and is it outdated to just say, keep your shoulders still. Not necessarily, it depends. Depends on A, your training, and B, your client and what they're trying to achieve. So I hope that was helpful, guys. Love having you along. Please ask more questions. We're going to be back here next week. It might be that we're doing this till July or something now, isn't it? What's that all about? So let's meet every Wednesday. Any more questions, please feel free to ask. Head over to the Biomechanics Education YouTube channel. Subscribe over there. You can watch all the old videos in there. There's a load of Army Freely classes in there as well, Bev, if you want to go and have a little nosy, some of the ways I've done it. Let us know how it can help. The biomechanics.com website, there are some anatomy blogs, and I'm just launching an anatomy video series where I have a little bit of fun with my friend, talking about the anatomy of the body and how can we better remember the language and body parts to help us help our clients. So you can go and check those all out on the website. But thanks for coming along. You're welcome, Roz. I will see you all next week. Thanks, guys. Take care. Have a good week.
Thank you, Rachel. Thank you, everyone.
Welcome.